here's an example of me filling out a mens form for a 53-year-old person who's about to undergo a lumbar fusion. So the first part is the procedure. I expect the procedure to take anywhere from 1 to 2 hours. I expect the patient to stay in the hospital for 1 to 2 days. Definitely not going to need the ICU. My blood loss is going to be less than 100 cc's. The surgical team size is important. It includes me, the anesthesiologist, the surgical scrub tech, the circulating nurse, the rep that's going to be in the room, plus anybody else that may come in to give breaks, so it's greater than 4. The patient is always intubated, so that's greater than 25%, and the surgical site does not apply, so adding all these up, that's a score of 19. Moving on to the disease-specific, non-operative treatment effectiveness was ineffective. There are no other treatments, we've already determined that. And the impact of waiting 2 weeks on the patient's disease outcome is minimally worse. Same thing with my ability to perform the operation. Impact of waiting 6 weeks, again, minimally worse, and because he's had symptoms the patient has had symptoms for a couple of years. Impact of a 6-week delay on my ability to perform the surgery is minimal. That gives me a score of 22. And then getting down to patient-specific, patient's 53, so that gives him a score of 4. He doesn't have asthma or COPD. He doesn't have obstructive sleep apnea. Like a typical American, he's got hypertension and takes 2 blood pressure meds. He doesn't have diabetes. He's not immunocompromised. He hasn't been exposed to anybody with COVID, and he doesn't have any systemic things to suggest that he's got COVID. So that gives him a score of 14. Adding this all up, it's a score of 55. And currently in Massachusetts, the cutoff score is 32. This patient would not qualify for surgery. And that's how we stratify risk and score patients.